Welcome back to the Health Longevity Secrets Show with your host, Dr. Robert Lufkin. His book, titled Lies I Taught in Medical School, is a New York Times bestseller. Download a free chapter from the link in the show notes. And now, please enjoy this week's episode as we look at the secrets of bioidentical hormone replacement therapy with Dr. Lauren Fitzgerald.
What if the key to feeling better at 45 than you did at 25 isn't about accepting normal lab values, but rather about optimizing your hormones to their ideal levels? In this eye-opening conversation this week, Dr. Lauren Fitzgerald, a board-certified anesthesiologist who now specializes in bioidentical hormone replacement therapy, challenges conventional medical wisdom about hormone health. Dr. Lauren breaks down the critical difference between bioidentical hormones and their non-bioidentical versions. This distinction isn't just academic, it has profound implications for safety and effectiveness. Now, while your doctor might tell you that your hormone levels are, quote, normal, those ranges often represent the average of an increasingly unhealthy population rather than optimal levels for vitality and longevity. Contrary to lingering misconceptions from outdated studies, bioidentical hormone replacement therapy has been shown to actually decrease cancer risk, protect cardiovascular health, prevent osteoporosis, and support cognitive function. For both women navigating perimenopause and men experiencing age-related testosterone decline, properly administered bioidentical hormones can transform the quality of life. So whether you're struggling with brain fog, fatigue, weight issues, or just don't feel like your vibrant self anymore, this conversation offers a roadmap to reclaiming your energy and zest for life through evidence-based hormone optimization.
This episode is brought to you by L-Nutra, maker of the Prolong fasting mimicking diet. Use the link in the show notes for 20% off. What if your routine CT calcium scan could tell you even more? Now from a single scan, you get 4 powerful reports, not just your coronary artery calcium score, but also your arterial age, liver fat levels, and bone mineral density, with no added radiation or time, spotting heart disease, metabolic dysfunction, and bone loss before symptoms begin. And now it's available anywhere in the US, no prescription needed. Use the code Lufkin20 for 20% off.
And now, please enjoy this week's episode.
Hey, Lauren, welcome to the program.
Thank you. It's so good to be here.
I'm so excited about today. What we're going to be talking about is bioidentical hormone replacement therapy. That's really important for both men and women, and we're going to talk a little bit about those. And actually, before we do that, I'm so excited. Our paths are crossing at an upcoming conference in San Diego. You and I are both going to be speaking at the World Link Medical Conference down in Coronado Island. I think it is. It's a beautiful spot.
It is.
We can plug it here. We'll put links in the program.
For sure.
It's really just out of full disclosure. It's aimed, as I understand it, you were there last year. It's
Correct.
aimed at
Correct.
more practitioners than patients.
Yes.
But yeah, what was it like last year?
Well, it was really great. We had some great speakers. Obviously, you're going to be awesome this year. But I will say that if you are any kind of medical provider, whether a doctor, a PA, a nurse practitioner, a pharmacist, naturopathic doctor, even a chiropractor, and you're interested in learning about hormones, but you're not quite ready to pull the trigger to do the whole certification, this would be a great place to just see what we're about at World Link Medical. And I'm not paid by them. Like, I just love what they represent. They're the first group of medical providers that are like-minded, that think outside of the box, like I have for a while. And after reading your book, I know that you're an outside of the box kind of doctor as well. I call myself a recovering anesthesiologist. I'm not sure if you call yourself a recovering radiologist, but but neither of us follow that stereotypical allopathic doctor path at this point that we're at in our lives, right?
Yeah. And it's so satisfying to see this space of health and wellness, like we talked about offline a little bit, is just exploding. So many people are realizing that
it is.
they can take control of their health. And,
for sure,
doctors, while they're important, health is really on you and I as patients. It's on me as a patient.
Absolutely. And I find that the more doctors like you and myself that I meet, we all have a very common, similar story. I just met another one. He's out of Malibu, Dr. Darshan Shah, who is a surgeon. And he too had his own, health issue that what he had learned in med school really wasn't helping him. And that's when oftentimes we're forced to think outside of the box. Like, well, what did I not learn? Like, why am I not able to be the healthiest version of myself based on all of my medical knowledge? And it brings a lot of us to this place where we're like, okay, there's more. And let's see how we can help other people do the same thing that we've done in our own lives. Right.
Yeah. I mean, that's such a familiar journey. I mean, I certainly went through that, and
Me too.
Many people, both practitioners, but also patients are discovering it as well.
For sure.
But maybe we take this opportunity as a segue and tell us a little bit about your journey and how you came to be interested in this fascinating area.
Well, I've always been interested in health and fitness. I was that weird person that I started teaching fitness when I was like in my teenage years. I've always been obsessed with the health and fitness stuff. And so I thought it was the next natural position to go to med school, because I've always, was smart in school, so I could use my brain to help people, be healthy. And then it was, I guess in the middle of residency that I realized, like, oh, I'm not really helping people get healthy. I'm just putting people to sleep. And I'm in this system that obviously I didn't come up with this phrase, but our healthcare system is actually a sick care system. And I found myself, I was only practicing my anesthesia career for 6 years before I realized, like, this is not what I wanted to do as far as, helping people in medicine. And that was also right around the time that I started having my own health issues. And so of course, here comes that story where it's like, all right, despite me doing all of the things, I was gaining weight for no reason. And I could not figure out it for the life of me. And I knew it wasn't what I was eating. It wasn't whatever. And that was when I first saw a functional medicine practitioner. And that was the whole concept of insulin resistance, which I'd never heard of. And here I'm an MD and I'm learning this from, someone that is, in this functional medicine world, which I had no idea what that even meant, integrative medicine, functional medicine. And that was in my mid 30s. And now I'm 45. And I mean, it's changed my life. I'm healthier at 45 than I was at 25. And I find a lot of patients that have a very similar story. They're doing all of the things right, and yet they're still either having problems with weight or brain fog or energy or autoimmunity. And they have been failed by the traditional healthcare system because, as you know, that system it teaches us how to treat everything with pharmaceuticals, procedures, and surgeries, but does not give the patient that's motivated, that wants to heal themselves, doesn't give them any tools. So here we are.
Yeah, and right now, I mean, obviously you're an expert on bioidentical hormone replacement therapy. You practice in, it turns out, St. Charles, Illinois, which is right there where I played basketball for the Naperville Redskins. Actually, I don't know what they're called now, but
if they're even around. I don't know if they're even around.
But so we overlap in that. But your practice is actually national, so you don't have to live in St. Charles or Illinois.
Correct.
Anywhere in the country, people can
come to
you, and
I've got lots of telemedicine patients that I've never met actually in person. So,
so that's the world of medicine today. It's very convenient now to access the best, even if you're not in the location where they are. So let's start on hormone replacement therapy. You want to start with testosterone or for men or for women? What would you like to do?
Can we actually, just for the listener, because can we define bioidentical? Because I am embarrassed to admit this, but I've been a medical doctor for 20 years, and it wasn't until the recent past that I actually fully understood the difference between bioidentical hormones and non-bioidentical. So I assume that most of your audience knows, but for the ones that are too embarrassed to admit, like, I don't really understand the difference, can I just define that first?
Yeah, it's a great point. And I want to make this as sort of an introductory lecture, so assume that I don't know anything, we don't know anything. take us through it from the beginning.
Love it. So when I use the word, so I think hormones is a umbrella term, and hormones can be bioidentical, so matches exactly the chemical structure what the body makes. So our ovaries, your testes, or non-bioidentical, very similar to what the body makes, but a little bit structurally different. And the difference is Big Pharma can patent one and can't patent the other. So Big Pharma cannot make money off of the same structural compound that our body makes. So progesterone is a great example. That is bioidentical, what our ovaries make. And you take a progesterone molecule, change it a little bit, and you have a progestin, which does not match what the body makes. And there is so much confusion around that. So they don't teach us that difference in med school. And it wasn't literally until almost 20 years later that I had to understand, like, I think that that's intentional for them to not want us to understand the difference between bioidentical and non-bioidentical. And I know that you're probably not the only one that has heard this before, but a lot of medical providers are told that it's just a scam. It's a marketing ploy or whatever. So for the longest time, before I understood that no, bioidentical is actually the way that you're describing the actual hormones that you're taking, and non-bioidentical versus bioidentical, there's a big difference. And the big pharma companies don't want us to understand the big difference because the big difference has everything to do with risk that are known. So for example, birth control pills. Birth control pills have progestins, not bioidentical progesterone, but progestins and estrogens that don't match what our body makes. Everyone knows, like, females are put on birth control without even thinking about it. And you know that you have an increased risk for clot. So that's a known side effect, but no one explains to you, well, it's because the non-bioidentical sex hormones that are in these birth control pills that are suppressing your ovulation are actually linked to increased risk of clots. They're linked to increased risk of breast cancer, all sorts of bad stuff. But patients are not really given true informed consent when they're started on these synthetic, or some people use the word synthetic. I like to use the word non-bioidentical, so it's a little bit more clear, but synthetic or non-bioidentical sex hormones, right? So when we're talking hormone replacement therapy, I always specify bioidentical hormone replacement therapy. So if you're following me on social media, I typically will say the 4 letters BHRT because I don't prescribe hormones that are not bioidentical, right? So when we're talking any kind of hormone replacement therapy, you need to ask your provider, do you only do bioidentical or do you do both? Because the most common one that was used for a very, very long time was Premarin. And Premarin is a great example of a hormone that they take literally 88% of the estrogens from Premarin don't match what the human female body makes. And they come from literally pregnant horse urine. So that's where the CEE comes from, conjugated equine estrogens. And those estrogens don't match what the human estrogens make in the body. And so there's just a lot of confusion around that. So is that kind of clear?
Yeah. So we need to request bioidentical hormone replacement therapy.
Absolutely.
Yeah.
Absolutely. The safety profile when comparing bioidentical versus non-bioidentical is very clear, but you have to know where the literature is because they don't want you to understand the difference between the two.
Mm-hmm. And let's see. So now hormone replacement is something that all women essentially will need for half of their lives, assuming they live to a good
Correct.
old age. And many men will also need it. It decreases over age with men, but all women will need it. But a large percentage of men also, right?
True. So let's clarify though, need versus want, because I'm 45 and I started perimenopause around 40. I could go the rest of my life and never replace hormones and be relatively healthy-ish, but I will not have the same quality of life if I don't replace my hormones to optimal levels. So it is not a need, it's a want. And, not everyone wants to take hormones in this stage of life, but I do believe that everyone would benefit from it. We just live in a world where we are bombarded with so many things that disrupt our hormones. So a man that's in his 60s 100 years ago had really great levels of testosterone, 900 to 1,000 or more. Now we're seeing men that are in their 20s that have really low testosterone. Is that because of one thing? No, it's probably because of a lot of different things that mess with our hormones. But I do believe that that you can be doing all of the right things, eating super healthy, exercising, prioritizing sleep, and still not have optimal levels of hormones. And that's why I believe that most people, once they hit midlife, are going to benefit from adding on hormones, bioidentical, of course, to their regimen.
And for women, postmenopausal women, where basically the hormone production really bottoms out,
Correct.
would you recommend that all women be on these?
Absolutely. Absolutely.
and-
I mean, just the prevention of cardiovascular, the number one killer of females is everyone's worried about breast cancer, but that's not the number one killer of us. It is cardiovascular disease. And once our ovaries are done making estradiol, which is the cardiovascular protective hormone, then our increased risk of having heart attack, all of that go up postmenopausal. So we can prevent cardiovascular disease, we can prevent osteoporosis, we can prevent dementia. A lot of people don't realize that osteoporosis is actually reversible with bioidentical hormones. They're not taught that, you know?
Yeah, there's this view. I think it started in the early 2000s. Actually, Marty Makary, who's a colleague that who just got elected to the FDA. Hopefully, we're going to get him on the show. But he's a great guy. He has a great book called Blind Spots, and he talks about he talks about hormone replacement therapy. And something that happened in the early 2000s with the Women's Health Initiative study about the association with breast cancer and hormone replacement. And it basically ruined a generation of women that didn't get access to that. Can you talk about that a little bit?
Yeah. Oh, my mom's generation is the generation that missed out on it. So knowing everything that I know now, it really makes me angry, because if I would have known, I would have started my mom on hormones when she was in perimenopause to have all the long-term benefits. Now, my mom, postmenopausal, almost 20 years, and I still started her on hormones when I did all of my training, because it is never too late to reap some of the benefits. But if you really want to get all of the long-term benefits for us females, it's ideal to actually start in perimenopause instead of waiting until menopause.
Mm-hmm. And so that scare about, or the issue about hormone replacement therapy in women causing increased rates of breast cancer was incorrect. Is that right?
Correct. It was poorly interpreted, and it was basically before this media got a hold of it, it was not adequately interpreted, and basically it changed a whole generation of misinformation. And still to this day, there are a lot of doctors that still believe that HRT leads to breast cancer, and it's just not right. Bioidentical hormone replacement therapy, it decreases risk of cancer. So that we've got to get that out there, because the fear of breast cancer, I think, is the number one reason why a lot of women don't even consider doing HRT.
Yeah, and so we can cross that off. Are there any other contraindications for a woman in perimenopause now considering hormone replacement? There are very few contraindications, and honestly, if a woman is actively fighting cancer, that would be the only one. And honestly, it is only because medical legal, because we haven't had studies of someone actively fighting cancer and being on bioidentical hormones. So it's more of because if it were my brother, my sister, my aunt, my uncle, that I wouldn't have to worry about them suing me, I would actually probably still have them on bioidentical hormones in the midst of fighting cancer. But that's right now really the main contraindication of starting hormones. And it's really to cover our butts. And that's for cancer. It's not all cancers. It's just breast cancer. Correct. And sort of jumping around with hormone replacement therapy for men, talking about cancers, we have the association with testosterone and prostate cancer. And it used to be that, men who had a history of prostate cancer, even if it was treated, would not take testosterone. What's the thinking on that now? Has that changed at all?
Yeah, it 100% has changed. It's actually protected. The only man that should not be on testosterone with prostate cancer is someone that has a super, super low level of testosterone. But anything above, I believe it's 250 or higher, it's actually protective against it. And we've seen that with both prostate cancer and breast cancer. She's still alive, a breast cancer surgeon, Dr. Becky Glasser, who who has done tons of studies on testosterone in her breast cancer patients, and it's apoptotic. So we know it's actually protective. So if, God forbid, if my dad ever had prostate, well, he's already on good dose of testosterone. So I imagine he probably won't develop it because I already have him on that protective level of testosterone.
Oh, that's interesting. And how about for patients who've had prostate cancer and then they've gone through hormone replacement, or they've
Totally
gone through
safe.
androgen suppression, and
Yeah,
then safe afterwards, right? So
absolutely.
you just don't want to do it during active disease, I presume, or
Correct.
yeah, for
Correct. And again, it's more medical legal, because if it were my dad, I would still have him on it during treatment, honestly.
yeah, yeah. And so for men, what we talked about some of the women's symptoms of lack of these
Yep.
hormones. What are the men's symptoms for lack of testosterone?
So I really feel like both men and women kind of have some very similar things that they complain about, minus obviously men don't have the hot flashes like women do. But the brain fog is very common for a lot of people at midlife, just low energy, low motivation, lack of desiring the usual stuff that used to bring them happiness. Testosterone is great. When I explain testosterone to both men and women, I explain that we've got sexual benefits and non-sexual benefits. I believe that there's a lot of married couples that at midlife go through divorce, and if they would have just gotten hormonally optimized, they could have avoided that. Truly. It's known that women go through the change, but men, the andropause is very real too. It's not quite as distinctive as our menopause, but there are midlife hormonal changes that, if you get a man hormonally optimized, he is a different person. And I love working with married couples. Those are my favorite. Typically I start with the female, and the female's like, oh honey, you're going to have to join me because you need to catch up. but truly, you get both people hormonally optimized and their world changes. The people think I'm being sarcastic when I say life-changing. I'm like, no, it really is life-changing.
Yeah, and I've heard people talk, therapists in the field talk about when they're working with couples like that, if they're going to treat one, they need to treat the other one. Otherwise, it could be a source of discord.
Exactly. Exactly. Yep. No, just this morning, one of my 3-month follow-ups, she's like, yeah, my husband's already like, I think I need to get an appointment with her because I can already tell a difference just in 3 months. I'm like, yeah, just wait. The first year, when they do hormones with us, we make them enroll for a full year because, as you know, nothing is fast with hormones, right? And so some people feel, I would guess probably about 50% already feel better in the first 3 months, about probably 75% by 6 months, and then almost 100% by the 9-month mark. So, and this is, true for both men and women.
What are some of the biggest misconceptions about this space that people get wrong, or that prevent them from coming in and getting the help that they need? What do we need to correct out there in sort of people's understanding of it, and practitioners too, for that matter? You're going to be speaking at this course, and talking to practitioners about this.
One thing that I really appreciate about WorldLink Medical is that we are taught that the understanding of these different medical society guidelines are actually just opinions. Okay. Follow me on this. So each society, so let's use the Menopause Society, right? The Menopause Society comes out with their guidelines every year, or not every year. I think it's every 5 years, maybe. So you would think that the most recent guidelines are based on the most recent literature and the highest quality of literature, but it's not always the case. In fact, Big Pharma has influence on these societies' guidelines. And so these people that are medical providers that follow guidelines instead of actually listening to the patient oftentimes will lead to patients not feeling their best, but we're following guidelines. So therefore, like for example, thyroid, if you follow endocrine society guidelines or thyroid society guidelines, you can't even consider treating a patient with thyroid unless they have a TSH above like 5 or something. Well, literally free T3 is what's active at the cellular level. It's almost 100% of the time. If they have a low T3, they have so many of the symptoms of a suboptimal thyroid. So I will explain to them, I'm going to start you on thyroid hormone, not because you have hypothyroidism, but because you have suboptimal thyroid. And so that's, against guidelines because their TSH is within normal limits. But I'm listening to the patient, and the patient is positive for literally every single symptom of a suboptimal thyroid. So why would we not treat the patient and their symptoms versus a number? The amount of patients that have come to me and said, I have an endocrinologist and they say my numbers are fine, but I have, weight gain, difficulty losing weight. I'm cold all the time. I've got low energy. I've got brain fog. I can't remember names, words, or numbers. I've got dry skin. My hair is falling out. I've got brittle nails. I've got constipation. I've got depressed mood. Like, these are all very stereotypical thyroid issues. We take them off of their synthetic Synthroid, which is levothyroxine. We put them on a good natural desiccated thyroid that has T1, T2, T3, and T4. And then we get them to the dose that make those symptoms go away. And it's like magic. And they think that I am literally the best thing since sliced bread. And they're firing their endocrinologist of 10 plus years. And this happens over and over again. And that's what I appreciate about WorldLink, is that they teach us that the guidelines are really influenced by big pharma. And if you don't just look at the guidelines, but you actually treat the patient and their symptoms, you will literally change their lives. And that's why, people that just go to a standard OBGYN that follow guidelines, some hormone replacement therapy is better than none, but almost never are they feeling optimized by the time they get to me.
Yeah, and another place I hear a lot about that is in testosterone replacement. Like, what is
yes.
what's your philosophy on that? Sort of the number to hit, or how do you evaluate that?
Well, this was so WorldLink has 4 different parts of their BHRT training, and each part is a full 3 days, right? And so in part 4, they taught us, and I had never heard this before, but we actually didn't even measure thyroid and testosterone until the late 1970s. So literally, doctors would just treat based on symptoms. So if you have symptoms of a low testosterone or thyroid, we just, hey, guess what? We increase it until the symptoms go away. It's kind of crazy thought, but literally, most men, I will always tell men, you're probably going to feel all of the symptoms of an optimized testosterone, and it's going to be labeled too high, labeled super physiologic. And that's typically where the symptoms of low testosterone go away. And the same goes with testosterone in females as well. So I always explain at the initial consult that at the end of at the end of 12 months working with me, most of your labs are going to be bolded and labeled too high. And that's typically where people feel best. And that's where I'm going to keep them at, because I know the safety profile of that is very, very well studied. So let's take females, for example, right? Our upper limit of normal on the labs, I think, is like 70. Well, Dr. Glasser, who I talked about earlier, she literally looked at, I think she had more than one study where she looked at that, the total testosterone level where the symptoms of low testosterone started to come back were below like 250 in a woman. So that's, super physiologic, but I've found this totally true in my clinic, where if a woman has their total testosterone somewhere between 200 and 300, all of those symptoms of a, low testosterone are gone. But you look at the lab, and a doctor that's not used to working with hormones, they'll freak out and they'll be like, oh, it's too high. Okay. And we have 30 plus years of data studying too high levels of testosterone in women that want to be men. And we know how safe it is. So if we get super physiologic levels, I will always tell my female patients, both female and male, but specifically with female, when we get our levels a little on the higher side, sometimes we can get the unwanted side effects. So some chin hairs, maybe some acne, maybe some hair shedding. But oftentimes, if that's not the case, then I will tell them, you feel good at this dose. I don't care that it's labeled high. That's where you feel good. We're good to go.
Yeah, and we so many times we're hearing more and more of this about how, as healthy people, we don't want to be in the normal range for lab values or anything. No. We want to be in the optimal range.
Exactly.
And normal in this country, sadly, is being
not
overweight
optimal.
or obese. It's
exactly
pre-diabetic. It's you're metabolically unhealthy, certainly.
Yeah.
So
yeah.
We hear that all the time.
All the time.
Can you speak a little bit about your approach to routes of usage? Injections, creams.
Yeah, for sure.
What's your philosophy on that, and what should people be aware of there?
So when it comes to testosterone, I give patients an option, and I explain why one is my favorite over the other. So like when testosterone, there's multiple ways to give testosterone. The most common ones are either pellets, injections, or creams, right? Oral is sometimes, but I've actually personally never prescribed oral because I like other options better, which I'm about to explain. But I give the patient the option because if at the end of the day, they're hearing why the difference of delivery of testosterone, if they still want a pellet, I will put a pellet in them. I think pellets are good for a certain patient population, like the little old lady at the nursing home that's not going to inject herself or put a cream on, right? So yeah, there's certain patient populations, but when we are trying to get your hormones optimized, we're trying to mimic what your hormones looked like when you were hormonally optimized. So that means when you were 19 or 20 years old, what did your hormones look like, right? And with testosterone, it peaks and troughs every 24 hours. So daily cream is my favorite way to do that. And it doesn't involve needles, which I'm not afraid of needles, but if you're going to be on testosterone, you're probably going to be on it forever. Once you realize how much better you feel when testosterone is optimized, do you really want to be injecting yourself once or twice a week the rest of your life with testosterone? I did injectable testosterone, felt decent, but I like cream so much better. And again, it most closely mimics that daily peak and trough every 24 hours versus peak on day one of your injection and trough over the next 7 days, right? So I explain to the patient and let them ultimately decide, but I typically talk them into creams, both men and women.
Yeah. So, and your practice, if I'm a telemedicine patient, let's say, what would they experience from your practice, or how would the encounter be set up, and what would that look like?
Yeah, the initial appointment is about an hour. We look at their labs. I typically, if it's telemedicine, I'll share my screen and we'll look at how their normal labs are not optimal labs. There is literally a book written by Dr. Neil Rouzier called Normal Isn't Optimal. And so I go through explaining how their normal labs are not optimal labs because they're telling me all of these symptoms. And this is why once for example, your free T3 is within optimal range, it's going to be labeled too high, but that's when all of your suboptimal thyroid symptoms are going to go away, right? So at the end of the appointment, I will explain to them, all right, after looking at your labs, these are the hormones that I think would be best to replace. I like to do them all at once. There's some patients that want to just start with one hormone at a time. Again, my goal is to give them the information if I meet them where they're at. So I have some patients that just want to, which hormone should I start with? Well, let me give my best, suggestion, but I like to hit them all with one or at once. So like, for example, my perimenopausal women, almost all of them need testosterone, progesterone, plus or minus DHEA, and almost all of them need thyroid. So those basic 3 to 4 hormones, I like to hit them all at once. And typically by that first 3-month appointment, because I see them quarterly in the first year of their hormone management program, they're feeling, if they're not optimized yet by 3 months, they're definitely feeling better by 3 months, right? So I'll explain to them. And then the compounding pharmacy that we use, it's a good quality compounding pharmacy that's used to working with WorldLink medical providers like myself. So they don't get excited if they see a higher dose of testosterone for a female. Like, for example, females that have high sex hormone binding globulin. So I'm super fit, and typically the metabolically healthier you are, you have higher sex hormone binding globulin. Well, that means that I'm going to need a higher dose of testosterone because I've got so much sex hormone binding globulin, and ultimately my free testosterone is what matters. So this pharmacy is not going to freak out when they see my higher dose of testosterone. That's not your standard dose for a female, but that's where I feel best. And that's where my free testosterone gets into that optimal range, which always is labeled too high. And that's where I feel best. And that's why I look and feel my best at 45.
There have been so many changes in this field in the last 20 years. We talked about the Women's Health Study and different thinking about hormone replacement. If you could, looking forward, had a crystal ball, looking forward 5 years, 10 years, where do you see this space, or what are the changes, or what would you hope for in this space?
I hope, because I always say hormones are bullets, they're not magic bullets. So if you really want to feel your best, it has to be combined with nutritional approach, with exercise, with sleep management, stress management. All of those things really do matter. A more holistic approach of all of the things, getting a person to their very best. I mean, my mom, she's 70 years old. She just had her total knee replacement. And I literally was the least worried about her going into the surgery than ever, because she is in better shape, healthier at 70 than she was even 10 years ago when she got her other knee replaced, right? So it's never too late to optimize your health and feel your best. And man, obviously the earlier that you can start, the better, because quality of life when you're in your elderly years has everything to do with how much muscle mass you have. And we need to start building that muscle, because it's not easy to build. But getting your hormones optimized with all of the things really will equal just an abundant, healthy quality of life.
And talking about muscle mass, we talk about that on this show a lot. And
Oh, good.
I never set foot in a gym. I mean, in a weightlifting gym prior to like
Really?
2 years ago. And now I go
I
every
love
single
it.
day.
I
And
love it.
it's like it seems like it's so important. How do you see
It
it fitting
is.
in with your practice?
Oh, I require patients to lift weights. We establish from day one that if they don't do what we ask, we will fire them because we don't want their bad results to make us look bad, right? And we know that weight training is really important. You know, I minimum of 3 days a week. You don't have to lift weights every day, but a minimum of lifting weights 3 days a week. And I will tell patients, if you are not comfortable in a gym, hire a personal trainer for 3 to 6 months. Literally start there because you don't want to injure yourself, obviously, but you also want to have someone that will teach you how to do it and challenge you so that you can actually start building muscle. And then, of course, if you're on hormones, it's going to be a lot easier to build muscle.
Now we hear a lot about muscle with, metabolic health and
Yes.
insulin and brain-derived neurotrophic factor for the brain health and all.
Yep.
How does it tie into hormones? It sounds like muscles are separate from that.
No, it's all interrelated for sure. For sure. I mean, your quality of life in your elderly years has everything to do with how much muscle mass you have. And I always tell my patients, I want to be able to give you the blessing of having a life like my great grandmother. She was 98 and still mowing her own lawn. She lived to 105 and she had great muscle mass. She was, she had no fear of doing hard labor. She wasn't lifting weights like traditional. That was before that day, but she did her own form of resistance training.
Well, I want to be respectful of your time, Lauren. Is there anything we haven't covered that you wanted to mention in this presentation?
Yes, I want to address the idea of overdosing hormones because there's no when I as a former anesthesiologist, when I hear the word overdosing, I think death, right? If you overdose someone on insulin, you can literally kill them in the OR. That was literally taught to me day one by one of my faculty members, that this is something that if you don't understand the right dose of insulin, you can literally kill the patient on the OR table if you overdose them, right? If you overdose on our narcotic, you will literally suppress your respiration to zero and die, right? There is no such thing as overdosing hormones. So if we overshoot, let's say testosterone or DHEA, the two androgens, right? In females, we can get some extra chin hairs, some pimples, some hair shedding, some androgenic side effects, right? But are you dying from that? No. And is that reversible? Absolutely. It's just tweaking. But this whole concept of hormones being dangerous, bioidentical hormones, the safety profile is very, very real, and you can't overdose it. It's just finding the right dose that gives you all of the therapeutic benefits of the right dose. And everyone is different, but you can't really overdose on bioidentical hormones. So I wanted to make sure that that was very clear because there's so much fear around it. And especially with testosterone and just primary care doctors that are not comfortable with it, I'm not fearful of too much testosterone. You cannot overdose on any of these bioidentical hormones.
Yeah, that's a great point. And coming from an anesthesiologist who knows
Exactly.
dosages and everything, that's
Exactly.
extra
Exactly.
attention.
That word is thrown around, and I just want to make sure that any providers that are in this space understand that that is really not a word that's appropriate to be used in the bioidentical hormone world.
Yeah, that's great. Well, listen, I want to thank you so much,
Thank
Lauren,
you.
for being on the
Yes.
program. Before we leave, could you tell everyone, our audience, the best way to follow you on social media, the best way to find your website? We'll put it in the show notes also, but for anyone who's just listening on the podcast, maybe you could spell
Yeah,
it
for
out for
sure.
them.
So I do most of my teaching on Instagram. My Instagram handle is Dr. Lauren Fitz. So it's DrLauren Fitz. My last name is actually Fitzgerald, but everyone calls me Dr. Fitz, right? And then my website for my medical clinic is called Larimar Med. And Larimar just means tranquility and healing. It's a stone out of the ocean in Dominican Republic that has all the shades of blue. And that's our, what we represent. We represent tranquility and healing in the journey. So larimarmed.com is our website. If you're looking forward to working with us, you can send my staff an email at info@larimarmed.com, and they'll be able to guide you from there.
I already feel more tranquil just hearing that.
I love it.
Well, I'm looking forward to seeing you in September in San Diego at the WorldLink Medical Conference. That'll be a blast.
Me too.
And,
absolutely.
And hopefully we'll get you back on the podcast again. But thank you so much for joining us today, Lauren.
Thank you for having me. It was my pleasure.
If you are enjoying this program, please hit that subscribe button, or even better, leave a review. Your support makes it possible for us to create the quality programming that we're continually striving for.
Can I start? Is it recording?
It's already recording.
Oh, sorry. This is for general information and educational purposes only, and it's not intended to constitute or substitute for medical advice or counseling. The practice of medicine or the provision of healthcare, diagnosis, or treatment, or the creation of a physician, patient, or clinical relationship. The use of this information is at their own user's risk. If you find this to be on the value, please hit that like button to subscribe to support the work that we do on this channel. And we take your suggestions and advice very seriously, so please let us know what you'd like to see on this channel. Thanks for watching, and we hope to see you next time. You should say that.
No, that's good. That's for you to say. I think that's very good. Do you like it? You want to do it one more time, or is that good? I think that was good.
Yes.
All right.
You need to save the recording.